Thank you, Dr. Carr. If I could ask you just one question to start off our questions for the next 15 minutes. If you were to put all of the pain treatment modalities in your role as a pain expert, approximately what percentage of all of those, where would you put the percentage for topical pain creams today?
You mean what people are actually using? I'm going to take a wild stab at this because, as you saw, one can obtain pain creams just by dialing a phone number and giving a credit card number. So these are not monitored. I mean, they're monitored in some way. I guess you could look at the amount of raw materials used by manufacturers, but that, I would say at some point, I'm gonna say it's closer to 50% than it is to 5 or 100%. If you consider too that just rubbing on something instinctively, which we know has an analgesic effect through selective stimulation of large diameter myelinated fibers, if you look just at that process, I would say a 50%, in other words, in the dozens of percent, rather than a single digit or close to all.
And in chronic pain patients, from a prescriber's perspective, we're going to get some prescribers' perspectives later today, but just in terms of traditional medicine and prescribing, where do you see that 50% shrinking to in terms of percentage of physicians or clinicians, licensed independent providers, suggesting or giving prescriptions for certain pain creams that could help?
I'm going to take a wild stab at an impressionistic guess, but if you look at the topical agents that are compounded on a prescription basis by licensed independent prescribers, I would say that's more like a 10%, 5 to 10%. I see some nodding of heads, but that doesn't mean people are not using them.
Thank you. Other questions?
So thank you very much. That was very concise. I think you've posed one of the sort of paradoxes that we're running into in trying to consider this, which you started off with a testimony by a patient on the ability to go online and go to CVS and pay $10 or $100 for a cream that may or may not have efficacy for the patients, versus the last slide you showed where a very thoughtful and careful selection probably of agents was appropriate and the patient got substantially better. And one of the issues that comes up is the patients being given an appropriate therapy for what they're being treated versus being sold other products that may or may not have any kind of efficacy. And I wonder if you could speak a little bit more about how to think about and manage those kinds of issues.
Well, this is emblematic of a much broader series of questions about precision medicine and what its role is at a time when we have to make population-based budgeting decisions. So I'm going to just throw out for the point of discussion. Maybe tomorrow I'll wake up and think this was a terrible idea, but I'm just doing this on the fly. It's like my oral anesthesia boards, right? So on the fly, I would say that one thing I'm not aware of would be the cost effectiveness analysis of various agents that are out there with an eye towards informing clinical practice guidelines in the following way. If you had 3 or 4 things that you could combine as a topical cream, it may be that the expense and hence the risk-benefit or cost-benefit ratio would be just as good if you just empirically had people try something, did therapeutic N-of-1 trials, rather than attempting to match the mechanism to the agent selected, which, as we know, is often very imprecise. We can't really say, or there's a mixture of mechanisms. So I would think that it may compare favorably from a cost-benefit point of view to have empiric trials undertaken according to a standardized protocol. That would be one of the first thoughts that comes to mind.
So if I could follow up, I agree with you, and from that perspective, I think the the concept of trying things in patients where we don't have a standard approach makes perfect sense in an organized way with appropriate issues that go on. One of the issues that gets raised is that there is at least a large amount of suggestion that there are therapies out there that work wonderfully in everybody and should be tried, and so lots of money gets spent on those things. And so I'm not really talking about the money that's spent to create a cream that might be of use, but really I'm thinking more about sort of the availability of hundreds of different combinations without any oversight necessarily, and without any control. As you know, I'm very interested in responders and how they do, but I wonder what your thoughts are in terms of the issue of these creams becoming more and more available relative to the opioid epidemic, and perhaps being pushed in a way that may exceed the evidence we have for their use.
No, I think you're making great points, and for those of you who are not aware, John has done some of the seminal work in understanding the meaning of responses and how to use that information in analgesic development. So I was tempted to actually refer to some of those. If you look at some of the protocol designs that have been advanced, to look at responders, to segregate responders, because they're the ones that are going to wind up taking the stuff. If someone's not a responder, they're going to stop soon anyway. I think that we could inform our deliberations by looking at those study designs and treat the individual seen in clinic as a subject of an experiment, of a clinical trial design or clinical trial, empiric trial, borrowing from the insights gleaned in part through your own work on identifying responders. So if there were and I think, by the way, this concept is very generalizable. I will remind my colleagues, we've been doing this for opioids for years. Putting aside the public health crisis of opioids, if you just look at who responds to an opioid, we've tended to use the cheapest and widely available things first, like morphine. But if that doesn't work, there's actually a literature that goes up through meta-analysis of randomized controlled trials on the topic of opioid rotation. And it seems to be both efficacious and effective, that someone, for reasons we may not fully understand, genetically, prior drug exposure, what have you, responds to one opioid better than they respond to a different opioid. In practice, we do this for adjuvants as well. I mean, we may try some adjuvant, like tricyclic, and that may not work, so maybe we're going to try an anti-epileptic drug, and that may not work, so maybe we're going to try a pregabalin instead of a gabapentin. We wind up at the end of the day doing a lot of empiric trials. That is actually what medical treatment is about. If you apply an intervention and you see how the patient does. So we are doing trials anyway. And I don't want to get over my head here, but I have an intuition that the advances in questioning how we infer causality in the biomedical sciences that are arising at a time of huge amounts of data being captured, but also calls for precision or personalized medicine. I'm sure the committee is already considering that, but I think these are quite relevant. So I'm going to fall back on that adage that, yes, we're in a crisis, but that is the sum of danger plus opportunity. This would be a very nice model system looking at topical creams to try to sort out causality and come up with thinking perhaps on a protocol or systems level and not just an individual molecular clinical trial level.
Carmen?
Thank you. You're a good friend. Are there certain populations of patients that you think might particularly benefit? And you talked about a couple of studies, and can you talk about the generalizability of those particular studies to the general population? I mean, so I guess what I'm asking is, where are the populations that some of the studies that you talked about used in a representative sample of what the United States or the globe would look like?
Thank you very much for asking that question. In fact, years ago I wrote an essay called When Bad Evidence Happens to Good Treatments. And the point of the essay was that if you wished to design trials that would not do justice to the efficacy or effectiveness of an intervention, you might assemble a cohort that had poorly defined pathophysiology, like low back pain. You would enrich the cohort in people who are on disability, because we know that frequently they don't respond as well. You would accrue a small number of people in your trial, and so you would weaken the power of the conclusions. If you go along that path, that's the pain literature. It's as if you're trying to bias the evidence against the efficacy. So I would say, yes, I do believe that there are subgroups. One obvious subgroup that comes to mind would be people who are at risk for substance use disorder or who have established substance use disorder. I would also point out that my colleagues in the public health department have enlightened me to the fact that we need to think about disease and its treatment in terms of 3 axes, not just one. The first axis is which molecule operates by which molecular level and through which pathophysiological mechanism, so sort of the molecular scale. But the 2 other important dimensions are who is the host? What are the characteristics of the host? What do they have? What's the meaning of their illness? What are its impacts upon social and family function and vocational function? The third is the environment. So you have a triad in public health of pathophysiology, host, and environment. Therefore, I think the first group that comes to mind would be groups that are at risk for or have substance use disorder. I'm very well aware of the recent study that found negative findings, but I think, I don't mean to get off and get granular on that, but I think there were several issues that would prohibit me from generalizing those negative findings to every case. First being that in many cases the pathophysiology was ill-defined. Second being it's a veterans population, very different than an oncology population in terms of mechanisms. The third, as I mentioned earlier, is that the magnitude of the effect size, if you look at the placebo effect size, the placebo was adequate in almost all patients. And we know from John's work, if you drop the pain intensity a third, let's say, that starts to become meaningful for people. So if you look at their data, the other thing was that they used an SF-12 for outcomes. And I can tell you, having come from the home, or the one-time home of the SF-36, it was never intended, that short form was never intended for pain studies. So I would say that I would be loath to generalize negative findings, but I do think that the key answer to your question would be those who are at risk for substance use. There's another whole dimension to this, which is that whoever applies the cream will be touching the person, and there won't simply be the selective A-fiber stimulation that reduces pain through gate control mechanisms. There will also be the human act of caring for someone, and I think that will influence expectations and outcomes as well.
Just to follow up on that, so what about the role of race or gender or socioeconomic class? Was that ever, so the studies that you looked at and they're talking about, did they make any comments about, is there any suggestion that there might be differences based upon that?
Again, I'm glad you brought that up because I would consider that a given. I just even didn't bother to say it because I felt that it would be a given that race, ethnicity, socioeconomic status, all would play a role. Family influences would play a role as well. And so in fact, you could say gender is a genetic thing. It has to do with an X or a Y chromosome. It's genetic. So I would say, broadly speaking, I just took it as a given that in referring in quickly in passing to the current debates about precision medicine versus population-based concepts of the evidence pyramid, that would just be a given. So I would say all of the above, and I thank you for making that explicit.
Extending from what you were saying in terms of thinking about N-of-1 trials or use of medicines, on one of your slides you indicated that perhaps a more important component than simply the p-value or the efficacy of a particular drug is the safety of the drug. And I wonder if you would consider expanding on that a bit from the perspective that we have a myriad of levels of safety and efficacy with the ones you were mentioning before. In oncology, we do give people very dangerous drugs to try and promote longevity and reduce their tumor burden. On the other hand, in the pain sphere, especially with things that may not have tremendous amounts of potential efficacy, it would seem to me that the safety of what we're trying to do would be paramount. And I wonder if you could speak perhaps to what you think, how safety might play into this, and what sort of safety approaches ought to be taken before things are tried in a more general sense.
Well, at this moment, I'm trying to organize what would be a lot of competing thoughts. I mean, as you know from existing FDA guidances, and these continue to come out in areas of relevance to topical analgesia, even this very month. There have been a number of safety-related outcome measures and assessments of where is the agent applied and what's the maximum use of that likely to be in clinical practice. I can tell you that the side effects of systemic absorption of ingredients in topical medications are actually described centuries ago. There was a whole tradition in apothecary science of mixing together dozens of things. This is the eye of newt and tongue of dog and so on. These were very well established, and I was just showing Dr. Schwinn earlier something I omitted, which was an account of an apothecary who was preparing one of these things in the 14th century, and it contained as one of its components opium, and some of it splattered on his thumbnail. Several hours later, he picked his nose, and then he became unconscious and his color changed. And then one of the medieval healers was summoned. So just because something is topical, it doesn't mean you can't absorb enough of it to have adverse events. So the systemic contribution, but this is a well-known thing. The local changes are well-known, and I understand that they would have to be assessed if you have an agent for topical use that's to be extended indefinitely. You would have to extend your observations for quite some time, like at least a year, let's say. The other issue of safety, and I think we're becoming aware of this dimension that we never used to think about, is the safety related to diversion or abuse. We have a whole enterprise of abuse deterrent formulations of various things, and I think in theory, one could apply an agent to a local area. There should be minimal systemic absorption, but it would not be as abusable, let's say, as an immediate release morphine or opioid product. So I think I have the feeling that every word I'm saying, though, it can be referenced to various guidances. But I think in general, if you had a small volume of material applied over a relatively small area, and you were augmenting that by the placebo response of expectation, the human gesture of caring for someone by rubbing a cream in, the selective stimulation of A-beta fibers, if you combine all of those, you may get some therapeutic benefit at what would seem to be homeopathic doses. But if the doses are homeopathic, I think their risk of diversion and abuse could perhaps be lowered. So I'm sorry to just grasp at a few things, but I do have the feeling every word I'm saying can be referenced to one or another FDA guidance already.
Dr. Sandbrink?
Yeah, I'd like to follow up just a little bit on the question that we had before. What kind of patients may be using this, right? We talked a little bit about race, gender, socioeconomic status. We also talked a little bit about, and you mentioned patients with a history of substance use disorder. But I'm wondering, trying to see this from two perspectives, right? On one hand, what kind of patient, like from the psychological makeup, may be using this kind of medication? We know catastrophizing, basically, and other patient characteristics may predict responses, to therapeutic approaches. So I'm just wondering if you want to comment a little bit more, if there's any information about what kind of patients may be seeking out, asking for this kind of treatment. And I understand that's very different possibly than what kind of patients may a provider choose to use this medication for. Maybe patients who are at risk from systemic side effects from oral medication. And then last one would, of course, and I know we have the provider's perspective later, is what kind of provider may actually prescribing this? So there are three different questions.
Just for the sake of conciseness, let me say I think those are wonderful points, and they make me think also a few years ago of your own interest in placebo. I would recommend to people that they procure the 1957 American Journal of Medicine article called The Powerful Placebo by Louis Lasagna and colleagues, because they had some wonderful tables of data, and I don't know what prompted them to ask these questions. It was just intuition, but they divided their subjects into placebo reactors, as they called them, we would call them responders, and non-placebo responders. And it was quite striking that the social interactions and social dimensions of the placebo responders were much stronger than those of the non-responders. So they would say things like, the staff were great, they cared about me. They also tended to be more active in church or social groups than the non-responders. So I think in your question, I could imagine a provider saying, well, you know, there's that standard medical stuff, it's the pharma industry stuff where we have this cream that several people have found soothing. It has these herbs, like that thing that I showed you in the ad. Would you like to try this cream? It's more holistic. So perhaps this begins to get at what I think is your incisive question about expectations versus modality versus content. I understand cost of naturally is a huge factor, but I think that it would be possible to do some type of a profile psychologically of expectations of the sort that one sees in studies of placebo nowadays, to try to identify on a behavioral basis who might benefit. Of course, we don't want to ignore, just we're taking it as a given, that we would like to link the mechanism of the pain, or what we believe to be the mechanism of the pain, with the treatment we apply. And that's why Dr. Weingarten's case was so interesting, because this lady had had all of the conventional things and was still suffering horribly. So we believe that these cases are not just placebo responders, but may have a more favorable response when what is applied matches the presumptive pathophysiology.
Dr. Cardenas.
Yes, thank you very much. I have a question about that last case. The two creams, the cream that was mentioned, they had the ketamine, clonidine, gabapentin, and then reduced the pain to 2 out of 10, but there was still breakthrough pain, then led to adding long-acting methadone and a long-acting bupivacaine, so an anesthetic. So my question is, once that is done, what is the thinking of the physician in terms of, do you ever remove any of those other drugs that, you don't know which was it the ketamine, the clonidine, or the gabapentin? Does the patient need the gabapentin, which can cause side effects if it were absorbed? I mean, it's just like you've added to the pot, but now you're not going to take out one of the three that didn't seem to work fully when you added the methadone and the bupivacaine. So what is the thinking in that case?
Well, in the interest of time, we actually have with us that physician, but I would say perhaps we could discuss that offline during a break. I don't want to speak for Dr. Weingarten, but my sense in hospice care is that if the primary goal is to render the patient more comfortable, and they are approaching their death to begin with, it becomes less important to decide which incremental factor has made them comfortable. It is not unimportant, but it's less important unless there's a side effect like hypotension from clonidine. Then it would be useful. But in terms of quality of life, I think that there's less emphasis on dissecting which agent might be critical.
We'll say they were 30 and not dying, and but still had pain.
Well, yeah, or even to go outside of hospice if you had someone with chronic pain who appeared to have benefit. I think just as in ordinary medical management with tablets, at some point, looking at the situation, looking at how well they're tolerating it, looking at the cost, looking at the cumbersomeness of the medication, At some point in just normal daily practice, one would say, well, let's back off a little bit. Let's lower that amitriptyline dose a little bit because you're a little constipated and you're getting an opioid, so we'd like to clarify that. I mean, I've done that clinically. Even apart from the hospice setting, if you have someone whose need is going to be open-ended, at some point, going back to the really what's a medieval recommendation, you want to give the lowest effective dose for the shortest possible time. So that's a background concept, but my point is that the concept may not be applied with equal aggressiveness in each case, such as hospice, which I would put at one extreme of comfort first, understanding mechanisms later. But
So-
again, Dr. Weingarten
Yes,
is here.
we've got a
and we can do that
microphone that
during
she
the
can
break.
use.
Yes, hi, thank you for that comment. And it was definitely some of the things that I was considering as I dosed that. But once I changed the cream and added the bupivacaine and the methadone, and the patient achieved comfort after approximately 1 year of suffering intensely, 9 out of 10 pain or 10 out of 10, and we achieved that comfort. I thought in my mind probably I could take out the clonidine and the gabapentin and it would be okay. But she lived 17 more days after I changed that cream and with the bupivacaine and methadone. So I didn't feel like as she was approaching the end that it was necessary to try to bring down the lowest doses that I could, because she had finally achieved, like I said, after 1 year of suffering, she had finally achieved what her goal was, to be able to sit up and to receive ADL care, with comfort. Thank you.
One
Okay.
last sentence, which is, this is not a conversation very much unlike the treatment of cancer pain through classical regional anesthetic methods of neurolytic block. Let's say giving alcohol to curdle a nerve that supplies an area that's invaded by tumor. If you're looking at the short term for days to weeks, injection of alcohol or other agents to kill nerves makes a lot of sense. But we know if you follow people long enough, they very often develop a neuroma as the nerve begins to recover and it overexpresses sodium channels and so on. So the decision-making is context dependent, and what could be a perfectly good intervention for someone who has days or weeks left would be simply not recommended for someone who has months to years left.
Dr. Carr, I'd like to say thank you very much. We've appreciated your insights, and we're going to move on to our next speaker now. Thank you.